to work on my books, my journal, Progress in Orthodontics, which is the #1 journal in the world in orthodontic space as far as impact factor is concerned. And then this is how it used to be at one time. You can see how it's changed over the last 50 years. This is where I live now, which is in Florida, next to the Atlantic Ocean, near Palm Beach. This is my golf course. I live on a golf course. It's a beautiful life. I travel all over the world, give lectures like I'm here. And this is my passion. Teaching is my passion. People always ask me, when are you going to retire? Never. Because, as long as I can teach, I would love to teach. So this is a very complicated subject, open bite. So in the next 45 minutes or 40 minutes, I cannot tell you everything about it. So what I decided is to talk a little bit about THAIs as far as the open bite correction is concerned. Instead of giving you basic information, I'm going to talk mostly about patients, lots and lots of patients. So we'll talk about conventional orthodontics a little bit, but mostly related with biomechanics, application of THAIs. Aligners I won't talk here because we already discussed a little bit, and we'll talk a little bit about stability. If you look at spectrum of open bites, there is no one definition of open bite, okay? So if you look at the soft tissue, what you will see is some patients have open bite, and they don't show upper incisors. She has a big open bite, not only she shows upper incisor, but she shows gingival tissue. And this guy, you can see, has a big open bite and there's a curvature. And this guy has a huge amount of open bite. So now you can see that you can never define open bite. Now we come into the cephalometric films. Look, when you read articles in the literature or in the books, people are always talking about steep mandibular plane, long face, this, it's okay. But take a look at it. Pretty good facial architecture, there's open bite. Steep mandibular plane, there's open bite. Very steep mandibular plane, open bite. Crazy open bite. So, skeletally, you can have flat mandibular plane, you can have steep mandibular plane, you have a long lower vertical facial height, short, open bites. Yes. Now we come into dental. It's a totally crazy situation because dental, you will see anterior open bite, posterior open bite, lateral open bite starting from the molars, starting from the canine, starting. So we are dealing with a problem which is very unique. There's no way to tell you that you can use this appliance to correct open bite. Every patient has to be individually treated. And that's why with aligners, it is very difficult to treat objectively an open bite patient. The reason for that is you can only do a few things. You can extrude primarily teeth, not too much, very difficult. So how are we going to treat some of these problems? And we are going to show you. So if you take a look at this thing, an open bite, I would have a treatment based on the degree of difficulty. And the degree of difficulty is going to be based on the soft tissue, dental, and the skeletal problem. If I have an easy problem, I can just use elastics. If I have a little bit more complicated problem, I may need more intrusion. If I have a more complicated problem, I may need some distalization, some easylization, different movements. Or I'm going to need THAIs. But I can do TADs here, I can use TADs here. So the nice thing about TADs is I can use them in any type of situations, easy to difficult. This is how I look at it. Where does this patient fit in? Is the problem dental, skeletal, or soft tissue, or combination of all these things? Let's talk a little bit about biomechanics. When we talk about biomechanics, and when we use these wires, we start putting bends in the wires. Every bend in the wire has a consequence. And this is showing you basically the 6 different ways you can put bends in. You can have step bend, you can have bracket or teeth are up and down, and your wire is straight, or you can have teeth leaning towards one side, and you will see both systems are almost the same. So which system I'm going to use if I'm going to correct dental open bite in my patients? Ideally, if you look at open bites, they are primarily because of the upper dentition, not because of the lower. Lower you will see a little bit steepness of the occlusal plane, but in the upper you are going to see the problems in the posterior region or anterior or vice versa. So when I want to use biomechanics in open bites, there are certain things are common with most of the problems. I always want to have an intrusive force on the molar. Why? You extrude the molar, you increase the open bite. I don't want to do that. The other thing is, I would like to make this occlusal plane flatter based on your treatment plan. So in some treatment plans, I need a lot more intrusion, less extrusion. In some, I want to keep the molar where it is, and I want to extrude the teeth because I want patient to show upper incisor while smiling. Different clinical situations. So, for example, if you look at 4 different scenarios of biomechanics, you have first what we call class 4 geometry, and that is in extrusion arches. And what you will see is that if I place a cantilever on this one piece extrusion arch, and I hook it on the anterior teeth, I'm going to have a force system. The reason I'm showing you this is that any time you place a wire in the mouth, you should know what you are doing. You decide what wire is going to do, not the wire deciding what it is going to do. So, if I do this thing, I'm going to have intrusion in the posterior region, and I'm going to have extrusion in the anterior region. But then what happens is the moments are going to be quite different. And that is, it is going to bring the posterior teeth forward and anterior teeth down, and the net result is you correct one problem, but you create another one in the posterior. So what do we do these days? What I would like to do is for you to place a TAD somewhere there, put in a wire, passive wire going into the tube, that is your indirect anchorage. Now you can do anything in the anterior region you want. There is no side effect in the posterior. This is where orthodontics should be done. Why does it take us to 2 years, 18 months? Because half of the time we are correcting side effects. And you want to use TADs so you don't have side effects. You can finish treatments faster. More predictable tooth is going to take place. So I'm not going to spend most time on these things, but take a look at good effect, reduces overbite, bad effect, occlusal plane changes. Very quickly showing you, if I use step bends, everybody thinks, oh, if I put a step bend, upper teeth are going to extrude. Well, that's maybe true, but you're going to have side effects. Force system is okay, moments are not. So next result is, if you don't have a tab in the posterior region, you're going to have a problem. So how do we get rid of this problem when you do these mechanics in your practice? You use boss elastics. So anything that you use up and down elastics, you are saying there's a problem in the lower, there's a problem in the upper, and there's equal amount of problem. Now the problem is primarily in the upper. Maybe I don't want lower teeth to move. So box elastics is not the best way to do it. A lot of you use, probably meow wire. But every open bite patient, you give meow wire. It does the same thing in every patient. You don't want that. You want different appliance, different force system, and all these different problems. So that's no good. And then I can say, if I use center Bgen, especially if I have an extraction patient, I put a loop in the middle, and I activate the loop, what is going to happen? Well, then we have opposite moments. So now you can see, in this day and age, all the side effects I'm going to take care of by using DAGs. If I don't want posterior teeth to move, I use DAGs. If I want posterior teeth to intrude, I'm going to use DAGs. I can use palatal DAGs, intrazygomatic DAGs, buccal shelf DAGs, different ways. So you can see this is another thing you can do. You know the side effects. And then the last one you can do in treatment plan is, okay, if I put a bend in the front, what is going to happen? Well, longer the wire, smaller the moment. Shorter the wire, bigger the moment. So, there you are. Force system in all these is okay. It is the moments which are going to create problems for you. So now you can see posterior is going to look pretty good, the anteriors are not going to look good at all. So we may need DAGs in the anterior. But we can, it's an open bite case. So we have to be very careful of the force system. So this becomes very important. Now we come into research, what goes on, okay? I'm an evidence-based guy. So this is a paper which we had published. A prospective clinical trial effects produced by extrusion arch, biomechanics. And you can see how many accesses it had. In a short period of time, we had 56,000 downloads in the social media. So you can see this study basically shows that if you use extrusion arches in a better control in the posterior region, you can do a very good job in closing the open bites. Now, what are the common sites for that as skeletal language application? One is my friend Dr. Sugawara, skeletal language system. In US it is rather difficult to use because you need a periodontist or oral surgeon to do it. The cost increases. Intrazygomatic tags, buccal shelf tags, and palatal tags. You are going to hear from Dr. Benedict Lucas about palatal tags a lot. I'm going to talk a little bit about intrazygomatic and buccal shelf tags. This is Dr. Sugawara's system. He always talked about that when you want to do bigger movements, you need these plates in the zygomatic bone with 3 screws, and then you need, if you are using it in the lower, you are again going to need. Now you can apply a force to retract the teeth, intrude the teeth, whatever you want, instead of using a single tag. The best system you can have, but it is difficult if you are not oral surgeon yourself. Very nice. Chính and I wrote a paper 2006, it was the best paper that year in AJDO, and I remember Kenji coming and getting an award there. And in this one, we basically talked about distal movement of the maxillary molars in ongoing patients with scapular anchorage. So you can see how we are intruding the whole arches. Then, this is another classic paper. 2004, it is the highly cited paper I think I have. You know, I have probably 300 papers. You can see it's very cited because it's one of the first papers which talked about intrusion of the posterior teeth. It was a case report only. And that was scapular anchorage to correct open bite. It was done with my friend Dr. Kilish and Dr. Najat Alvardi from Turkey. So what do you see? You see here is I work with people internationally. I met Junji sitting on the second chair in 1980 when I visited Sendai. I was visiting professor there. And then Junji spent 2 years with me. Dr. Najat Alvardi, he spent a lot of time with me over the years. And I'm going to show you some of the cases with Dr. Masco Almeida, who started coming in 2011 in Connecticut. Now, I think he's probably one of the best orthodontists in Brazil. So you can see, Flavio, look at the screen, please, not your computer. Dr. Uribe, please, he's the chairman in Connecticut now. He thinks he knows everything, you know. You can still learn a little, please. Okay. So you can see, very simple device which we use. This is showing you historical. This is just to give you an idea that suddenly biomechanics plays a big role with the TADs. Because when the TADs came in, everybody thought, oh, now our problems are over. Well, the new problem started. Where are you going to put TADs? What relationship to center of resistance? What is the relation to the line of force to the center of resistance? Oh, really? You have to do that? A lot of research came from Korea. A lot of excellent studies came from Korea because they took it over. So this becomes very important. Same thing in the lower. If you're going to use a buccal serve tag, what is the relationship of the force to the center of resistance? So for example, I'll show you later that this is from one of our books. You will see if the force is above the line of center of resistance, I can retract the teeth, I can close the open bite. Same thing I can do with the upper by putting the line of force in relationship to center of resistance. These pictures are at least 25 years old, 20 years old. So application of TADs to apply cantilevers. This is a famous paper from Dr. Uribe, I think. But I took it over from him. Because anything which your students or faculty does, it belongs to the department head, right? You know that? So this is a fantastic treated case just to show you. Okay? Take a look at this patient. Scalically, there are no issues. He looks fine. Soft tissue-wise, there is a problem. Dentally, there is a problem. There is an open bite. Now, you don't want to change the posterior occlusion because it's pretty good. So Dr. Uribe started calling this targeted mechanics. You know, the terminology comes from medicine because these days in medicine, there are a lot of medications which are targeted. That you want to take care of the cancer, but you work with the cancer instead of doing the whole medication systemically. So instead of putting brackets on all these teeth and putting a wire and all that, having side effects, the idea here is keep the posterior the way they are, put a TAD here, indirect anchorage, or right from the TAD, the force to move the teeth. But in orthodontics, we are like slaves of brackets and wires. Anytime patient comes in, put all the brackets in the mouth.
Nhưng mà trong chỉnh nha chúng ta hay có một cái khuynh hướng là mỗi lần bệnh nhân đến là gắn
So we're going to use a force system here of our extrusion arch, because what we want to do is we would like to put a extrusion arch to bring these teeth down, take care of the side effect in the posterior region, move the lower teeth a little bit up. This is what I call precision orthodontics. It's not like you put a liner in the mouth, go home, see you in 3 months. Okay, take a look at it. So, now what we have done is, we have indirect anchorage from the tag, extrusion arch is going into the molar tube, no effect on the molar. We are going to bring the anterior teeth down. So take a look at all that curvature. Occlusal plane is now flattening. So we go here, we go here. This treatment can be finished very fast. Won't take too much time to finish. And then, when you are ready to finish, you can put brackets on the posterior teeth and arch wire and finish up the patient. Okay? Now, if I was in private practice, I would finish it very fast. But when you are in the university, you teach your students and you move the molar a little bit like this, and the canine has to be very good and all that. So this is what we call targeted treatment. No change in the vertical dimension. Very little intrusion. You're not going to get much intrusion in any case, the majority of these patients. And you can see the long axis of the teeth look pretty good. You finish up the patient very, very nicely. So how much auto rotation of the mandible takes place with intrusion of the posterior teeth? Most of the studies are going to tell you it is going to be about 2.5 or 3 degrees. You are not intruding too much, so the auto rotation is not going to be too much. Okay, so if somebody tells you they can auto rotate a lot, just scratch your head, okay? It's not going to happen. So take a look at it. They looked at 42 articles and they talked about 2.3 to 3.9 degrees. Now we come to open bite correction, the whole arch distalization. This is something beautiful happening with dads and orthodontics. And we are applying the same thing now with aligners. So when I gave my talk the first day, I just said that any time you have open bites, space closure, you want to use tabs, use palatal tabs, use it for zygomatic, whatever you want to use. I'm not selling anything, okay? You can use whatever you want. But most of the tabs when I was in Connecticut, we used fluorescent tabs. Because I've worked with fluorescent very closely. Now they have come up with the newer system. More tabs. Take a look at this patient. It was done in the department. We didn't want to do surgery. Now she wanted surgery. So we said, okay, let's retract the whole lower arch. This patient has been done a long time back. We are using the Vao-Wioc system here. We set up the lower arch with as large a rectangular wire as you can. In the upper, you leave it alone. You don't want to do too much in the upper. So sequentially, we are going to change wires, put in there. We are going to apply a force above the center of resistance. So not only we will go back, we will close the open bite also. You want to put as heavy a wire as possible because you want to use all the lower teeth as one unit, as a single tooth. You don't want to use over 6 or over 8 wires. And then, as you are coming back, you can change the position of the elastic. You can go from here to there. Why? Because shorter elastics are going to have more vertical forces.
Tại vì khi á, mà cái thun mà nó ngắn lại á, thì cái
Bye bye, Dr. Mentor.
cái
Have a nice time.
của
Thank
tự
you.
nhiên nó nhiều hơn.
So,
Nó đóng cái hàm nhiều hơn.
take a look at it. So clinically, we are doing basically the same thing. So this is our occlusal plane, how we would like to bring it back, how we like to change. And you can see we start with here. You can see all the way front, and then we are changing.
Đó là cái cách mà tôi đã sử dụng.
So now you can just,
Bây giờ khi mà kéo
you have retracted all the lower teeth
rồi thì
back.
mình chỉ cần là không
What do you learn? Because whenever you do these cases, you learn something. You know, not
nếu mà các
everything
anh
goes
chị làm
right.
điều này á, là các anh chị
When I
học
look
hỏi
back
được
at
cái
these
ca này.
cases, I
Khi
said,
mình-
oh my
khi mình
gosh,
nhìn lại
look
cái
at
cây
this,
này,
you know.
tôi sẽ thấy,
The
trời ơi,
canine is very prominent.
các anh chị thấy nhìn không? Cái răng nanh
Because when
nó
you're
là
bringing
cái
this
phần
whole
răng
arch
nanh.
back, you're going around the corners,
Khi
you're
mà-
going to see the
Khi mà chúng
canine.
ta đem nguyên một
They
cái
go
con
a
răng
little
phía
bit
sau
more
á,
toward the
thì cái răng
corner.
nanh nó sẽ là
So
cái đứa
over
mà đi
here,
qua cái góc,
what you have to
góc
do
cuối
is
của
you
cái
want to
con
make
hàm
sure
ha. Cho
that
nên
the
lúc đó mình phải
canine
rất
roots
là
are
cẩn thận
in.
nha, cẩn thận, và cái chân răng nanh nó có thể nó bị lòi ra ngoài.
You
Tại vì
finish
đó
with the
là cái
patient
răng mà nó
pretty
sẽ
good.
di chuyển đi qua cái góc uốn cong
We
của
could have
con
done
hàm.
better, but again,
Thì ở
this
đây
is the
các chị
start.
thấy
When
là
you're starting
bệnh nhân
something
nha,
new, I'm showing you
nó là
beginning.
tốt đúng
Now
không? Các chị
everybody
nhớ
is
cái lúc
doing it.
này á, là một trong những cái ca đầu tiên mà ứng
So you can see how it started. You can see the canine roots. You could have done something better. But as far as the patient's smile is concerned, it's good. She looks pretty good overall.
Nhưng mà nhìn chung thì cái ca này vẫn
So
tốt.
what happens with open in between? I put these pictures there to show you what happens with mechanism of open bite closure with TADs. We published this paper in Progress in Orthodontics, and we basically talked about when you use these aligners, for example, without TADs. When you close the open bite, it is primarily because of IPR. You do in these cases, and then you bring the incisors back, and the lowers back, they come higher.
Và khi mà nó đi thọc vào
Primary
trong á, thì
open
tự nhiên
bite
cái phần cắn của nó sẽ
correction
thọc
is
xuống
because
dưới
of
đúng không?
relative
Thì lúc này là
distance.
tự cái cắn hở nó đóng lại. Nhưng mà cắn hở đóng lại không phải là
Aligners
do sự thay
don't
đổi
include
xương hay là do
posterior.
lún đằng sau hay là hàm đóng lại.
In latest
Mà
study
chính là cái
came
hiệu ứng của cái cầu xoay á,
from
nó-
Invisalign patients
nó-
in American
cái
Journal
răng
of
cua nó dựng
Orthodontics.
tự nhiên nó dài xuống rồi. Chứ nó không phải là
0.07
một sự trồi
millimeters
ra
of
tuyệt
intrusion.
đối.
And the error of measurements was 0.7. So that means there was no change. None whatsoever.
Cho nên thật sự nếu
So
mình
you have
nói
to
mà
be very
cái cây
careful.
liner nó có thể làm trồi răng nó
I'm
không
showing
phải
you
là trồi răng mình
original
đâu.
patients,
Thấy nó trồi
older
chẳng qua là vì nó
patients.
dùng cái trục lại và nó trồi
Take a look
thôi.
at this young boy.
Thì mình hãy xem cậu bé này.
Interestingly, here is the midline.
Các anh chị nhìn
Upper is here, lower is there.
nó ở trên, nửa trên ở đây, nửa dưới.
Open bite.
Cắn hở.
We could have treated this patient several ways.
Mình
We
có
could
thể
have
điều trị
given
bệnh nhân này có nhiều cách,
elastics,
có thể sử dụng
asymmetric
tiền
extraction.
hàm, nhổ răng.
But you know, when you are at the university, you want to do something.
Nhưng mà ở
Different.
trường đại học
All open bite patients are going to receive some kind of a tongue grip in the back.
thì tất cả
I
những
don't
cái
like
bệnh nhân cắn
spikes.
hở ha, bao giờ cũng gần như là
I
bao
like
giờ cũng
nice rounded
đặt
things so
một
that
cái
they
chặn
just
lưỡi
remind
ở
the
hàng
tongue not to
trên
go
ha,
back.
mình để kiểm soát cái lưỡi nha.
We are going to use the same heavy arch wire. We are going to use a hook on one side, and what we are going to do is basically change the arch.
Và chúng ta đã thay
And you
đổi
can see no treatment is going on in the upper, just a buccal segment and anterior segment.
chúng ta chỉ có
Nothing in
đi
the upper.
xa một bên thôi ở hàm
Only elastics are being used on one side with a coil spring,
cái hông á, và cái
and
lực
typically
phá
we
nó
use
bên
about
một bên thôi.
250 grams of force.
Và có tạo ra cái lực khoảng 50
So you
gram
will
thôi.
see
Thì ở đây các
the
chị
midline shift is taking
là
place.
cái đường
Midline shift is taking
cái lần
place.
đường chữa là nó bắt đầu được sửa chữa.
It's a pretty slow process. Takes about 18
Thì cái
months.
này nó mất
to
thời
get
gian nó
where
phải
you
tới
want.
18 tháng luôn á để có
And
thể
then in the upper, you can see since our open bite is more on one side, less on the other side, we are using a differential cantilever, a two-piece cantilever on each side. One has more extrusive force than the other side until we get a good relationship in the anterior region.
để khi mà để mình chỉnh sau khi mà
So
mình
midline
thấy
is
là
being
cái
corrected.
tương quan nó đúng rồi.
Dads,
Sẽ ngưng cái cantilever.
cantilevers are taking care of the
Thì
asymmetric
khi á
open
nha mình
bite.
dùng cái cantilever mình nhớ
So this
nha,
is our
mình dùng
patient,
đó
this
để
is how
cái
we
tác dụng
finish.
phụ của nó.
This young man.
Thì đây là kết quả
Not
của
the
con
best
bé này.
conclusion.
Cái khớp
It
cắn
looks
tốt
much better than what he had in the beginning.
nó tốt hơn rất là
So
nhiều
these
so với
are
tình
the
trạng ban đầu.
earlier studies, earlier
Thì đây
cases
là những
which we
cái
did,
mà ca rất là
and we
xưa
find where
rồi,
we
những
are
cái ca
at
rất
this
đầu
time.
tiên, những cái bài báo đầu tiên mà chúng tôi sử dụng
Okay.
TAT để điều trị cắn hở.
Let's take a look at it. Comes from my friend Marcio Almeida from
Đây là
Brazil.
một
Work very
bác
closely
sĩ
with
bạn
him.
của tôi ở
I
Brazil.
talk to Marcio all the time. He calls me his biomechanics father.
Tôi hay
Okay, so
gọi
take a look at it,
nói
what
chuyện với
he's
Marcio,
doing,
ông gọi tôi
using
là
a
cha
force
đẻ của
system
sinh cơ học
in
mà.
multiple ways. He and I have written many papers together. This is one of the papers in Brazilian.
Chúng tôi đã cùng nhau
And
với nhau
we are
bài
using
báo. Đây là một bài báo
infrazygomatic tags
những công thức ở
and
ICC.
buccal cell tags a
Ở
lot.
góc phần sao nè, rất là nhiều.
The stability of
Cái công thức
infrazygomatic
cắm
tags
ở
is
cái chỗ
not very
này á,
good.
ở cái
But the
ICC
more
á,
you use, the better
nó
it
không
gets.
có quá.
So oftentimes people get up and say, oh, there's a study from UConn, you know, 30%, 40%
Nó sẽ tăng cái tỷ
loss.
lệ thành công
The
hơn,
residents are putting in, you know. So anytime you read these studies which come from universities, it's very different. If you talk with CHৰীষ্টan, for
Nếu các
example,
chị nói
he
chuyện với
uses
Christian á,
infrazygomatic
thì
tags.
ông ta sử dụng
He
rất là
says
nhiều
6%.
với nữa ICC.
So the more you use, the better you're going
Thì
to
cái
be.
tỷ lệ rớt của ổng ở đâu đó có 6%
If you talk
thôi
with
á.
Marcio
Cho nên
Almeida,
nếu như
very,
mà
very
mình sử
low
dụng, mình
problem.
cắm quen rồi á, thì càng ngày mình càng thả.
Simultaneous correction of open bite. I want to show you a case from my friend Marcio.
Thì xin trình bày một
Take a
cái
look at this case, just like buccal occlusion looks pretty good, and clearly there's a problem. He likes to use little spikes on the inside, which I personally don't like. So take a look at it. Using the biomechanics system,
sử dụng cái hệ thống lực giống như vậy thôi, giống nãy giờ.
he has determined the occlusal plane, and he would like to extrude the anterior teeth, maybe
Thì anh ta thấy
extrude
là
the lowers a
quyết
little
định
bit,
là
and
sẽ
at the
làm
same
trồi
time,
răng cửa hàm
he
trên
wants
một
to
chút xíu,
work
làm
on the
trồi răng
basis of
cửa
where
hàm
the
dưới
center
một
of
chút xíu
resistance
ha.
of the upper arch and lower arches, and how we are going to apply a force
Và sẽ di
where the
xa
whole
cái khung
upper
răng
arch
trên,
is
khung
going
răng
to come
dưới
down,
phản ra
maintain
cho
the
cái
lower
phần
arch.
qua tâm cản nha. Rồi thế là mình sẽ kết thúc được bệnh nhân có những cái mục tiêu đó, làm trồi răng trước ha, rồi di xa đi
Okay?
qua tâm cản.
Then you can use up and down elastics if you want,
Thì các anh chị có thể
asymmetric,
sử dụng
symmetric,
không lý
finish
hàm
up
cũng
the
được
patient
nếu mà mình muốn ha, không có cấm cản gì hết.
very nicely. Usually he shows also the number of months it took. It typically would be about 40 to 60 months of
Cái ca
treatment.
như vậy á, khoảng từ điều trị trong 14 tới 16
Take a
tháng.
look at the long axis of the teeth.
Mình nhìn cái
Pretty
cạnh
good.
dài của cái răng nè, nó tốt đúng
So
không?
anytime you are doing a distalization of the whole arch, you got to take the third
đi
molar
xa
out of the
toàn
picture.
bộ cái cung răng á ha.
You don't want the
Phải
third molar.
sử dụng, mình phải chụp lại cái phim để xem là cái
Okay,
trục răng nó còn tốt không.
showing you how much change, 12 degrees of occlusal plane change in this patient.
Rồi, trồng phim ở bệnh nhân.
Let's take a look at another patient.
Mình nhìn một bệnh nhân
Asymmetric
khác nha.
open bite, patient went under,
Cắm hở
I
hai
think it
bên,
may be
cắm hở bất
different.
đối xứng.
Patient underwent condylectomy. This is from University of Connecticut.
Đây là bệnh nhân
I
của bệnh
think
viện
Dr.
của từ trường đại
Uribe
học
was
Connecticut.
probably
Có lẽ là bác sĩ
the
Uribe
instructor.
là cái người hướng dẫn.
So you can
trong
see
cái
asymmetric
ca này.
growth is going on. This patient had a condylectomy.
Ở đây bệnh nhân
12
đã
months
được
of
cái phẫu thuật cắt
intrusion
đầu lồi
with,
cầu á, ở một bên.
infrazygomatic tags
Thì
in this
bệnh nhân đã
patient.
có cái
Our
vết
launch is going on
ICC
at the
nha.
same time.
Và sử
9
dụng
months of finishing in this patient.
sử dụng cái cơ học mà nãy giờ
Just
tôi
to
đã
show you
nói
what
ha.
tags can do.
Và có
If
chỗ
you were
răng
talking about open bites
ở đây
all
nó
day,
cần
you
khoảng 9
can
tháng
spend
thôi là đã
15-20 minutes
hoàn
talking
tất
about
rồi.
this case. No case goes in straight line. A lot of times you have in-between problems, but you are correcting those
Các chị biết
problems.
đó là không có
And
một
once
cái
you
ca
have
điều trị nào
established
mà
the
nó dễ
protocol,
dàng, nó đi
the
suôn
next
sẻ một
patient
đường
is
thẳng
going
từ
to
đầu
become
tới đuôi
much,
hết.
much
Thế nào trên
easier
đường
for
đi nó
you
cũng gặp rắc
at the
rối
same
thôi.
time.
Nhưng mà mình phát hiện ra rắc rối
So
mà
there's a
mình phải
patient at the
suy
end
nghĩ
of the
động não để
treatment.
giải quyết những cái rắc rối trên dọc đường đi. Chứ đừng có
Compared
nhìn
to
một cái
what
hình
she
trước và sau mà
was.
tưởng tượng cái ca này là
Buccal
đối
short
với nhau.
tags to destabilize the whole
Bây giờ
arches,
mình sẽ đến
simultaneous
cái
correction
nào
of
thành
open
buccal
bite.
thì mình có thể
Take a
dùng
look at
để
this
di
case.
xa cái cung răng.
On the left side, I'm showing you
Ở bên
level
trái nha.
4 problem. in
À,
this
là
case.
đây là nó nằm ở cấp độ khó số 4.
If you take a look at
Mình nhìn ở đây.
buckle shell tab there, line of force.
Mình nhìn cái đường
And you can see now what is going to happen. If your line of force is above the center of
nếu như mà cái
resistance,
đường lực của
the
mình nó
whole
nằm ở
arc
trên
is
tâm
going
cản
to go this
thì
way,
toàn bộ
and
cung
open
cao
light will
nó
be
sẽ đi
corrected.
theo hướng này, nó diễn ra nhưng nó sẽ xoay và đóng lại cái cắn hở phía trước.
My friend Marshall Almeida does a beautiful job with
Marshall
all
đã
this.
làm một cái
So extraction of the molars
bây giờ mình nhổ răng số
is
8.
going to take place. And take a look at the amount of class 3 on
Giờ
each
mình
side.
nhìn nha, ban đầu á là nó hẹn
Now
ra
you
như
can see a
vậy.
heavy wire is put in.
Bây giờ đã lên được
A
cái
lot
dây
of
cân
times you may
số
start
rồi.
with 1725 and change to 1825 or
Dây 18, 25 hoặc là
you can use
19,
stainless steel, you
25
can
như
use
stainless
titanium
steel hoặc
wires.
là titanium nha.
The length of the hook is very
Cái chiều
important
cao của cái hốc
because
á,
you
rất là
don't
quan
want to
trọng.
go below
Tại
the
vì
center of
anh chị á,
resistance.
không
You're
muốn
going
đi
to open the pipe.
cái trong ca này là không muốn cái lực nó đi dưới tâm cản mà nó phải đi
Everything
trên
is
tâm
based
cản
on
nha.
biomechanics.
Còn nếu trong trường hợp mình muốn nó đi dưới tâm cản,
take a look at
thì
it.
chỉnh cái lực hút. Tất
How much
cả mọi thứ đều tùy
visualization
thuộc
has
lớn
been done in the Lord?
phải phân tích cái cơ
Now
hội
we
của
have
cái ca
class
đó.
1. And now you can go in and put in braided wires
Rồi lúc
to
này
finish up the
thì
patient,
đã tới giai
And
đoạn
I'm
4
skipping
mình
a
đặt
lot
cái
of
dây
wires
ở đây
in
để
between,
làm cái kết
which
thúc.
have been put in these cases. The idea here is to show you the spectrum
Cái ý tưởng ở đây là không phải trình bày một cái ca mà tất cả mọi bước từ nhỏ tới lớn nha, từ cái giai đoạn dây, mà ở đây là trình bày cho các chị thấy một cái chân trời mở ra cái khả năng mà mình có thể sử dụng tát để mình có rất là nhiều khả năng sử dụng tát để cắn hở.
because he said when people become slave of the system, they will say, I do
Thì
my
bác sĩ
progressive.
Boston á
I
là
do
có
buckle shell.
một
I use
cái
cigar.
câu nói nổi tiếng
You
là
should be able to use
các anh
it
chị nên
if
học
you
cái
want
nguyên
what
tắc,
is the best
cái
for a
nguyên tắc
given
nha,
patient.
chứ đừng có học giống như cái khí cụ, tức là học pháp chứ đừng có học chiêu.
Take a look at it,
Nếu như mà
amount
học
of
được các
change
nguyên tắc
which
rồi
we
á,
want
thì
in
cái
the
khí cụ
patient.
nào họ cũng sẽ ứng dụng cái nguyên tắc đó để họ điều trị được hết á.
Distalization.
Và ở đây là Lisa.
There we are,
Và
from
chúng ta đã đến đây.
clinically, and take a look at it, the long axis of the teeth.
Và hãy
You
nhìn
don't
cái
see
trục răng nè.
jumbling of the roots in these cases
Chúng ta
because
sẽ thấy rằng
they're using a heavy wire to bring all these teeth back
ha,
at the same time.
thì ở đây mình thấy những cái chân răng nó không có
There's
bị
our
lộn
patient.
xộn, tại vì cái dây mà mình đặt cái lúc mà
Finished
mình
at
đi
the end of the
xa
treatment,
toàn bộ
cross
dây răng nó là một cái dây
occlusion
cứng
both
chắc, dây
sides.
lớn, nó giữ sự ổn định của tất cả những cái răng tương đối với nhau nên những cái chân răng nó không có lộn xộn.
And cephalometric changes. My friend Benedict Wilmus is going to talk this
Thì bác sĩ
afternoon. I
Benedict
did a couple of papers with
đã
him.
có xuất bản một
But he
vài
publishes a
cái
lot.
bài
He's
báo
always in my books. Whatever books I do,
và
he
đã viết một cái chương ở
contributes a
trong cái
chapter.
bài bút bài
He's the
sách
guru,
của tôi.
along with Bjorn Ludwig from Germany.
Thì ông đã
And they have created a
kết hợp với một
wonderful
số bác sĩ
system.
khác ở Đức
It
và
works
tạo
beautifully
ra
in
một cái hệ
maxilla.
thống nó
It
rất
works
là
very
hay
nicely
nha.
because you can distalize the teeth.
Vì với hệ thống này
Take a
chúng
look
ta
at it.
có thể
What is the
diễn ra
nice
tất
thing
cả các
about
răng.
it? The
Thì
nice
hay
thing
nói ở
about
đây
this
là
is that before they started using tags, we were using wires to distalize the teeth.
thì trước khi
Now
sử
we are
dụng
using
tát
tags,
chúng ta đã
and
sử
you can
dụng
do
dây
unilateral,
dây để làm
bilateral.
di xa
You
răng
can
đúng
have the
không? Nhưng mà
force
đây
closer
là
to the center of
có
resistance of
tát
the
đó thì
posterior
chúng ta
teeth, but
để có
all
thể
from
sử
the
dụng
palatal
tát
side.
để mà di xa toàn bộ cung răng
Now
ra
these
cho cái
days,
đường
they
liên
become
quan của cái cung
very
răng đó
important
nó
for
hạn
us.
chế những cái
Why?
tế bào chúng ta không có mong muốn.
Because if I'm using aligners,
Nếu mà tôi sử dụng aligner,
especially if I'm using our shape memory aligners,
đặc biệt là những cái aligner
and I have a class 2
có cái trí nhớ đàn hồi á,
patient unilateral, I can have a palatal tags inside and I'm
thì đặc biệt là nếu
distalizing
như mà bệnh nhân có
one
cái cắn
buccal
hở một bên
segment.
chẳng
At
hạn
the
hay
same
là
time, my
một cái sai
aligner
lệch bất đối
is
xứng chẳng
aligning
hạn,
the other teeth.
thì á, tôi có thể sử dụng
Sometimes
công
I
tác
can
để
leave
trong
the
cái cổ
molar
cái
more,
ra và nhớ
work
cái
on that
aligner
anterior
đó nó
teeth.
ôm rất là sát
When
á,
the molars are
và tôi
class
sẽ
1,
ứng dụng
I
lực để
can
tôi
put
kéo
glue
lui
them in my whole
một bên
aligner.
điều chỉnh cái bất đối xứng đó.
So, as we move,
Thì khi
we
mà chúng ta
adapt.
di chuyển, chúng
This
ta
is the
thì
way I look at
chúng
it.
ta sẽ thích nghi.
As we
Chúng
move,
ta càng
we
bước đi
adapt.
thì chúng ta sẽ thích nghi với những cái tình huống mới.
This is a paper was published
Đây là một cái bài
in
báo
2020.
xuất bản năm 2020.
My name is there because they liked me. Otherwise, I don't think I did much in this
Là
paper
tại
other
vì
than I
họ
was
mấy
their
ông tác giả ông
department
thích
head.
tôi á, rồi để tên tôi
But
vô
the concept
danh
is
dự,
something
chứ tôi
which
chẳng làm
I
gì trong
love.
cái bài báo này đâu. Nhưng mà
So
tôi thích
you
cái
can
ý
see
tưởng
it's a
ở đây.
jumble of wires in the mouth.
Các anh chị nhìn thấy nha.
I mean, we can use Benedict's system, but Benedict's system in university you don't have money, so you sit down and you, okay, let's devise ourselves. So you can see we have tags, we know about the force system, and we are trying to include the whole upper arch in these cases. So you can see the lower arch, there's our patient, or we can include the buckle. One of the nice things is that when you are using a system yourself, you can adapt as you go along. In university, sometimes things don't go in the straight line because you're teaching. Sometimes they go, oh, next time patient comes in, oh, gee, it looks worse. Let's fix the problem. So you can see the system works very, very nicely. So, if you are in private practice, Benedict will this is a fantastic system, pre-formed. You just put it in the mouth and you're ready to go. And you can see inclusion. And you can use from the buccal side also infrazygomatic tags so that you don't constrict the arch. In this case, we have the parallel arch going on with the screw. So it just shows you sequentially how these changes took place in this case. 5 months, 6 months, 7 months, and then you take a look at it, how we are changing the force system. You can see these hooks are very strategically placed so that when we are using the force system, we are cognizant of the fact that where the center of resistance of the different teeth or buccal segments is going to be. So there we are, you can see occlusion looks pretty good, and nobody wants to tackle with this third molar because of the mandibular canal. And there's our patient at the end of the treatment.
Còn đây là cuối lúc điều trị.
Open bite is closed.
Bây giờ cái open bite nó đã đóng lại.
Next patient, she's 29 years old.
Bệnh nhân 29 tuổi.
There she is. Two parallel tags in this patient.
Có hai cái con vít ở trong cổ cái
nha. You can see the system here using in the posterior region.
Hệ thống lực này ha, cái hệ thống khí cụ này.
Inclusion duration 12 months in this patient.
Mình làm đúng răng
And there she
12
is
tháng.
at the end of the treatment.
Và sau này
These pictures
lúc
are
này là kết thúc điều
when the
trị.
brackets are removed.
Lúc này là thốc tháo mắc cài.
So treatment duration is 2.8 years. That's a long
điều trị
time.
là gần 3 năm á, rất là dài.
But you can see she's happy. Occlusion
Nhưng mà
is
các
very
anh chị
good.
thấy nó xứng đáng ha, khớp cắn
Smile is
đẹp
very
nè,
good.
bệnh nhân cười đẹp nè, bệnh nhân
One of
vui
the
vẻ
things you
nè.
will notice here is that all these studies in
tất
the
cả các nghiên
literature,
cứu này
inclusion,
á,
when you do,
là chúng ta sẽ thấy
with whatever
khi mà
system
chúng ta
it is,
làm
never
đúng
going to
răng
be
phía
more than
sau
2.5.
ha.
If somebody
Nó
says
không
I
phải
included
là
4
đúng mục tiêu
millimeters,
á,
I'll
là
just say, oh, okay,
2.5,
I can't do it. You can do it.
2 ly rưỡi
2.5 is the
2 ly
maximum.
rưỡi là đúng tối đa rồi.
Maybe
Bây giờ
3
xài cái khí cụ
sometimes
tuyệt
if
vời
you use
nè,
Dr.
một
Sulavana's
lúc
system.
2 ly rưỡi
There's
thôi.
our patient during the retention phase.
Đây là bệnh nhân trong giai
You
đoạn
can
duy
see
trì.
it stayed pretty good.
Mình thấy nó khá là tốt.
So this is another case
Đây
which
là
is
một cái
published
ca
in
khác được
JCO
published ở JCO.
recently. It is a premolar extraction case, I
Đây là
think.
một cái ca nhổ răng khối
And you
nhỏ
can see
và các
pretty
anh chị có thể
severe
thấy
open bite in this case.
cắn hở rất là nhiều ở ca này.
Shows you how the planning is done, how the
cái lập kế hoạch điều
post-inclusion
trị của
system
mình
has
là
been
tập
created in this
sẽ
patient.
lúng răng nè.
How the force system is being changed every time the
Mình sẽ
patient
có thể
comes
thay
in.
đổi cái hệ thống lực nha, cùng một cái khí
You
cụ
are
trong
not
trung
using
bình
the
thôi,
same
nhưng mà có lúc
elastic,
mình
same
dùng
force
lúc mình
system.
dùng nó để kéo lôi ha.
And you can see sequentially that how it has been changed. And one of the things you'll see is not everything is going on in a straight line. You can see here the occlusion got into a little bit of a problem. Many reasons. Elastics can break, the screw can come out, and you will see some. But you go back and start again and finish up the patient pretty nice. With a good smile, good occlusion.
Thì bây giờ bệnh nhân đã
Cephalometrics, take a look at
đóng
it.
được cái khớp cắn rồi.
Almost no intrusion as such. Primarily, it is relative closure of the open bite.
Các anh chị nhìn ở đây á,
even
là
so, a lot of times when we are using this intrusion force, it is keeping the mandible where it is, not actively intruding or auto-rotating.
là nó đang cố
So
gắng
there's
ví
our
dụ
patient.
coi cái răng cối
End
nó
of the
trồi
treatment.
thôi, chứ thật ra nó không có lúng cái gì hết.
4
Tưởng
months
tượng ở đây mà
extension,
để trồi nữa
24
thì
months
tình trạng sẽ rất là tệ ha. Cái
Stays
cắn hở phía
legal.
trước á, là do mình nhổ răng
Smile
mà
is
mình kéo
good.
răng luôn thì sẽ đóng cái
His
cắn hở.
hairstyle is good.
Ha. Bệnh nhân là tóc đẹp ha, răng đẹp, tóc đẹp, mặt đẹp luôn.
Management of open bite with
Thì
Invisalign
là một bài
appliance, as I
báo
told you,
là
this is the very
mình điều
latest
trị
paper.
cắn
Oh, no,
hở.
this is
Ha.
2017.
Sử dụng
You know,
Invisalign
we
để
did
điều trị những
basically
cái
talk
vấn đề
about
về độ cắn phổi.
next time you can correct and this one is
Thì mình sẽ thấy là
1.5.
maximum mà có thể điều trị
This
được
is
là
a
chỉ có
paper which
1,5
came in
ly mà thôi
22,
nha.
oriented.
Nằm hai bài
Talks
báo này
about treatment of
xuất
open
bản
bite using
2022
non-extract
là 2
clear aligner therapy.
ha. Thì
Again,
cái
all
đây
these
nó
studies
chỉ có
basically show
thể
us the
điều trị
changes
được
are
ở
very
đâu
small.
đó
This is the latest
trong một
study.
cái
We
khoảng
talked about
một cái
0.7
phạm vi rất là hẹp
millimeters of
và giới
intrusion.
hạn mà thôi.
These are all Invisalign cases from THÄI, Ruse, University of Seattle, University of Washington in Seattle. This is our classic case. We always finish our open mind lectures with this case.
Những cái ca cắn
Because
hở rất kinh điển.
I especially put it there in honor of Junji Sugawara, who is sitting here.
Thì tôi đặt những cái ca này vào
Junji,
trong
this
sách
is the
của tôi,
case.
trong những bài giảng của tôi để
The lapse
ghi nhận công
took
lao
place.
của
Patient
bác
walks
sĩ
in.
Sugawara.
Doesn't want the
Đây là một cái ca
surgery.
relapse nha, một cái ca
So
tái
what are we
phát.
going to do?
Ở đây chúng ta
We
làm
place an arch wide in the upper anterior and the posterior. We are going to intrude the posterior
chúng
teeth.
ta sẽ làm lúng những cái răng sau.
We set up the lower arch.
Thay vì ở
And then what we are going to do is we use the Sugawara system to put
chúng ta
in
sử
plate
dụng
in the
những
next
cái plate của
in the
Sugawara.
zygomatic bone as well as in the lower. The lower
ở
force,
trên,
intrusive
trên
force
và
is
dưới.
just so that they don't extrude.
Thì mình đưa cái răng
But
vào
primary
cái
change
răng
is
cối
going to
đằng
be
dưới
in the
vô cái
upper.
con vít á, là
So
chỉ
what
là
we
để
want
mình
to do
trộn
is
nó, đừng có cho
we
nó
want
trôi
to
nữa
bring
thôi.
this occlusal plane up to the level of these teeth. We don't want to do anything with the anterior teeth.
Chúng ta chỉ muốn chỉnh
So
cái
you
phía
will see
sau
in
với
all
chỉnh cái
these.
mặt phẳng nhai để mà
This is
nó
from
đẹp
one of the-
nguyên một cái
one
hàm
of the
dưới nó
pictures.
ráp lại lên nó hàm trên
Junji's
như cũ
chapter
rồi
in
ra
one of
chẳng
my
muốn
books.
thay đổi gì cái răng trước hết đâu.
Placement sites.
Ở đây là những cái chỗ mà mình
So
cắm
take a
cái
look at
nẹp.
it, how we place these.
Đây là cách mà ông ta
So
đã
there's
cắm
our
những cái con vít
force
cái nẹp.
system, you can see.
Với cái hệ thống này các anh chị có thể
Nothing is
nhìn
going
thấy.
on in the anterior region.
Đó, chẳng có
In
gì
the
xảy
upper
ra
or
ở
the lower.
ở phía
So
trước
take a
đâu
look
nha.
at it, the
Mình cắt
force
phân
system.
đoạn rồi nha. Răng
Now
trước
we
là
have
một
a
phân đoạn,
cantilever
răng sau
coming
là
in
phân
on
đoạn
that
khác.
side
Rồi bây giờ
because
mình
we are
dùng cái
including the
cantilever
canine
ha,
also.
tại vì mình chỉ muốn
Buccal
lúng
is
cái răng
included.
nanh mà thôi.
And you can
Chứ
see
mình muốn
how
can thiệp vô
the
cái
open bite is closing
không
because
cắn
of
vào
the
những cái răng phía
intrusion
má
of the
mà thôi
posterior
để cái hàm nó có thể đóng lại vào phía
teeth.
trước
Now you can
thôi.
see. So what do you see? That I am not using the same force in the posterior region and
Các anh
each
chị
and
nhìn
every
sẽ thấy
visit. Force is changing. Sometimes I'm moving the
các anh chị
posterior
nhìn
teeth,
thấy không, ở đây
canine,
nè cái cơ
until
hàm
I
nó
can
dùng phía sau nó
I
có
can
nổi,
put
nó
a
không
straight
phải là một
wire
cơ
on
học
the
nhất
patient.
định nha, có lúc dùng cái cantilever, có lúc dùng thun, có lúc cột nó vô.
So there we are.
Nó rất
Now
là
we can
đa
put a
dạng.
straight wire in this patient.
Rồi bây giờ khi đóng lại được rồi thì còn cái giai
So
đoạn
if you
cuối
take a
cùng
look
là
at
cái dây thẳng vô để mình làm
7 visits which took place, how the posterior intrusion
chúng ta sẽ thấy sau 7 lần
closed
hẹn
the
là
open
mình
bite
nhìn nè,
in this case.
phía sau nó đã được lúng và
You will
cái
see
khớp
how
cắn
much
phía trước tự
intrusion we
động nó
did.
đóng
Yeah,
lại nha.
2.5.
Các
One
chị có nhớ
millimeter
không?
change is about 2.5
Chỉ thay đổi
2.5
đóng
degrees.
thay đổi một
Closure.
một
There's
mm
our
ở
patient
phần
at
sau
the
á,
end of
thì
the
ở phía
treatment.
trước nó cái trục nó đóng lại là 2,5 độ.
This is during the retention phase.
Ở đây là cái
This is
3
3 years
duy trì,
retention.
3 năm sau duy
And
trì.
we have followed this patient over the years quite a bit.
Và
You
chúng
can
tôi
see
đã theo
overall
dõi
changes
bệnh
of
nhân
the-
này theo một thời gian.
Stability of open bite.
Rồi khi mà mình nói á, vậy chứ mình lúng răng
You
xong
can
rồi
see
á,
that
nó
you
có ổn
can
định hay
lose
không?
about
Thì chúng ta thấy nha,
1/3 of the
chúng ta biết đó
intrusion
là
of the
cái lượng
posterior
mà mình đã
teeth
lúng được
regardless
á,
of it.
nó sẽ
So what
tái
does that
phát
mean?
1/3.
If I intrude 2 millimeters, I'm
Nhưng
going
mà
to lose,
tôi đã lúng được
I
2 ly
will
á.
only have left about 1.2
Thì tôi sẽ
millimeters.
còn lại sau thời gian chỉ còn là lúng được khoảng 1,2.
So, you know, a lot of times you look at these
Nó sẽ có
patients
cái tái
and
phát
we
là
say,
30% như vậy.
you know, I wish I could have done something different. This is the case
Đây là một cái
done in the
cây
department.
là
I think it's been published also.
nó cũng đã được
Done with
publish rồi,
aligners.
được làm với
You can
aligner.
see.
Các anh chị có nhìn thấy cái này nè.
So when we are using aligners, you can see
Khi mình sử dụng aligner,
she had surgery done. We
rồi
are
sau đó
really
bệnh
going to
nhân
use
trải qua
tags.
phẫu thuật và có
just to
cái
keep the posterior teeth in
chỉ
good
để giữ
alignment
cái
and
răng
finish up the
dưới
patient
cho
very
nó thật
nicely.
là
My time
đẹp.
is finishing,
Thật
so
ra hết
you
giờ
can
rồi, hết
see
giờ rồi, cho nên bây
a
giờ
lot of things which we did.
các anh chị
So,
sẽ thấy là
what
bây
is
giờ
the take-home
bây
message?
giờ đem về
Scatter
nhà
language
thứ
facilitates
nhất
open
là
bite correction.
tá sẽ giúp cho
Biomechanics
chỉnh
allows
sửa các hở
simultaneous
nha.
correction of open bite and moral
Thì
occlusion.
cái cơ học của mình
THÄNS
nó
allow
sẽ cho phép
inclusion of
mình
maxillary
chữa các
arch
hở đồng
only.
thời á, là chữa được
Relapse
cái
of
cơ quan
posterior
phía sau
inclusion
luôn.
can be 30 to
Để
35%.
mình đúng mà
Aligners
đúng
without
thì
THÄNS
hai
do
bên
not
nó coi nha.
effectively include posterior teeth, and retention is
Mình
long
sẽ bị
term
tái
and
phát
may
30 đến
include fixed
35%
dual retainers
để
and
align nó
positioners
cộng
over a
tác thì
long
sẽ
time.
không hiệu quả lắm
I
đâu.
received a phone call yesterday and a message from Dr. Flavia Ortese that somehow this has not been mentioned at the meeting here, and she's inviting all of you to this meeting in
Thì
Rio.
xin chào mừng
So
các anh chị
she
đến
sent me
cái
this
hội
picture.
nghị
I thought
này.
I'll put it here to all of you. I will be there with Dr. Kenji and we'll be giving a 2-hour course on shape memory aligners there.
Và cái chủ đề của chính
These
nó
are
là
some of the
những
books.
cái
Those of
liner
you
có trí nhớ
listed,
dễ
that's
nha.
the newest book,
Và xin giới thiệu
which
những
is
cái
coming out in a couple of
sách
months,
mới nhất của tôi.
and hopefully I will see you there.
Và
My
xin cảm
acknowledgement,
ơn
first of all,
tất
to
cả
amazing UConn residents who did
những
some of
đồng
these
nghiệp
cases.
ở Đại học
Flavio
KHÁI,
and Nilu Farasmi, who's program director, Kenji Ojima, I work very closely, and Marcio Almeida, I
và
work very
Mario
closely.
là những
So
người
with
đã
this I
cung cấp
will
cái
finish.
tài
I
liệu mà
took
tôi đã sử
maybe
dụng
2
trong cái
extra
bài
minutes.
ngày học bài trình
Thank
bày
you
ngày
very
hôm
much.
nay. Cảm ơn các
I
anh chị rất
enjoyed
là
talking to
nhiều.
all of you. It's a wonderful conference. My greetings, thanks to all of you for putting together a wonderful show. Thank you.